Thank you very much, Dr. Hazekamp, for this wonderful presentation. Our next speaker is Dr. Mario Castro from Pittsburgh, our own. Dr. Castro is a cardiothoracic surgeon in the Division of Cardiothoracic Surgery here in Pittsburgh. Welcome, Dr. Castro. He will be talking to us about when and how to operate on babies with complex transposition, the UPMC experience.
Thank you, everybody. Thank you for the committee for the invitation, for Dr. Morel and Dr. Laura Olivieri for this invitation, for the presentation, and for my Mexican friends in YouTube. I just want to say hello. So I'm ready to start the presentation. And my talk is when and how to operate a complex transposition. And the purpose of my talk is define what is a complex transposition, the evolution of the TGA management, and there's the relevance of the anatomic approach. And at the end, I will show some of the outcomes that they already been presented by Dr. Morel. So in the definition of the complex transposition was the ones with a VSD, left ventricular outflow tract obstruction, and other malformations that in this one side add on the interrupted aortic arch I was considered. And all these patients represent approximately 25% of the TGAs. And from the history, this is not different from the pediatric heart surgery history. They go by hand. And you can see it from the Blalock-Handler procedure that was an atrial septectomy, one of the first palliative operations. And then the Lily High and Barco tried to do the partial venous switch, and the baffles operation in the atrial switch by Senin and Muster. In 1975, Dr. Yatin did the first successful arterial switch. That's what's the game changer. But the reality, until 1984, Aldo Castañeda was the one who reality bring the switch for the neonate. Consider also the Dr. Jakub, the preparation, and the last one, the rapid preparation for the TGA patients by Dr. Jonas. And you can see basically the line, the history and how they've been changing from the Muster Senin to the arterial switch. And you can see all the procedures through the years. Also, we need to consider that the Rastelli procedure was done by Giancarlo Rastelli, that he has the idea when he was a fellow at the Mayo Clinic. So basically in the initial era, we were considered like the atrial septectomy, and the second area is basically when they talk about the baffles like the Senin Muster, and the different outcomes were not that great at that time, but also the evolution of the pediatric heart surgery was completely different. And this is slides that you can see basically the Blalock-Handler, that it was off-pump procedure. Basically, they opened the atrium and they ripped the septum. I never seen one, but probably when you read the history, it was like a tough procedure, you know. I mean, when you see the interventional cardiologist pulling the atrium, it's a tough procedure. Open probably it's more. And I'm a surgeon, so in the consideration. And you can see the Lily High procedure, the K-cross operation, the Senin and Muster as a procedure. And then we come in for when they start considering the third era, the anatomic repair, like the Rastelli procedure, done by Giancarlo Rastelli when he was a fellow at the Mayo Clinic. So in the third era, we already considered that Dr. Yatin, when the surgeons start dealing better with the coronary artery bypass, moving the coronary buttons, so they became the idea to do the arterial switch and procure these buttons, and that's done by Dr. Yatin. Let's see, I'm going to show you back this image. So this is from the original paper that you can see the description. And lately, when I consider the fourth era is when the anatomic repair for the root translocations, that gives better anatomical correction, decrease the ventricular dysfunction, avoids the limitation of that right ventricle and gets a better exposure that we already see. So when and how we're going to consider these operations. And there's a few things that we always need to consider: the degree of the LVOT, the pulmonary valve anatomy, if it's bicuspid, what is the coronary pattern, and where is the VSD location. And sometimes, and for the young people, I always said this is one of the landmark papers that you need to read it to understand the different types of anatomy that you're gonna deal and what are the different options, because sometimes a small resection of the LVOT commissurotomy on the pulmonary valve can take you to arterial switch and a minor procedure than a less complex than a root translocation, a Cairo procedure, or that requires more technical skills. And in this operation, Dr. Hasekamp review all the anatomies, specimens, and then describe when it's considered to do arterial switch, LVOT relief, when he consider like which patients you can consider for univentricular approach, which patient should have more severe LVOT that require an Cairo, Rastelli, and it's very, very nice paper to evaluate these specimens. And he has this table where basically which procedure committed to which of the lesions that we can find. Like you can see it that if there's a subvalvular tunnel, it's more difficult to relieve the resection, has a pulmonary valve, so those are the patients that you should consider do a more complex procedure. And always in the consideration in all these studies, if the pulmonary valve is small, if the LVOT is more complex, all these patients end up getting like an Rastelli or a Cairo procedure. And in these studies, it's most common do Rastelli procedure when they have a coronary anomalies. If they don't have any coronary concerns, most likely they will consider doing a Cairo. If there's a small LVOT obstruction, you can consider do a resection of the LVOT of the membrane and do the arterial switch. On the other considerations, this is from the group in Germany. Also, when they compare Rastelli and non-Rastelli, most likely the patients, or when they consider do what they call the half turned switch, that is like a double root procedure, it's when they can consider that they can preserve that pulmonary valve. And all these papers, Dr. Hasekamp already comment on these ones. And also from the Boston group, what they show in this paper, the smallest the pulmonary valve, it's more dependent to have reoperation, and these patients are more required to need an Cairo procedure. That is the most important. And it's always in the consideration if the pulmonary valve is a small preoperative, the consideration to have a Rastelli or an Cairo procedure. Now, other of the options that when the VSD is distal, the pulmonary is posterior, this also in having in mind the pulmonary root translocation, but one of our, described by Dr. De Silva, one of our partners here at Children's Hospital of Pittsburgh, he's not only the cone expert, he can do the root translocation. He will feel so proud. And our outcomes here, I'm gonna show one of our fellows, Dr. Cease, she reviewed the data and basically to try to create like an algorithm to make the decision for which patient we need an Cairo, for which patient we need a Rastelli. And that was the purpose. She reviewed the data from 2004 to 2020, totally 63 patients. Some of the ones they have incomplete follow-up, we excluded. She also excluded one of the aortic arch reconstruction, and we have 16 patients in Cairo, 18 patients for the Rastelli, and you can see that here is the anatomy and the difference. And the conclusion we got is, I think this paper basically is the reflection of the mature of Dr. Morel Carril. if you ask me, because basically he's saying like the pulmonary annulus more than 5 millimeters, that you have a space for that doing an echo to avoid that right ventricular hypoplasia. And if you ask me when is the consideration for right ventricular hypoplasia, this is like the group decision when we discuss and we consider that the way we're gonna do the reconstruction, if we do a Rastelli or intraventricular baffle, we're gonna have obstruction of the cavity of that RV. And that's when, given that space to move in the root, you do not decrease your right ventricle cavity. And that's what the consideration. And the VSD can be remote. You can still do the Nikaido. If you have a straddling, he already mentioned basically this algorithm. And this was the purpose of this paper, to consider where basically our mind for doing Nikaido. But we're not saying that Rastelli is a bad procedure. Rastelli is a great procedure. And, and there's not one size fits at all. And you need to consider, if you don't have these elements, the patient will be a good candidate for the Rastelli. Now, in these slides, you can see it like the anatomy of the pulmonary valve. The coronary anomalies were almost equal. Attachments of the AV valve, not consideration. And the reality, you can see it when there are any concerns, like from this in the RV hypoplasia, you can see it that we did not do any Rastelli on RV hypoplasia. And I think this is the message of part of these slides. And we already mentioned the Rastelli patients come back earlier for conduit replacements. And our Nikaido procedures, we always leave like the free PI at the beginning. Some of them in the first ones, they have a monocusp, and then they develop after free PI, and they come back later for some of them for pulmonary valve replacement. And we have at least 6% moderate aortic regurgitation in the follow-up on this paper. So at the end, we can consider that the outcomes are very similar between the Rastelli and the Nikaido, only consideration that the selection of the patients. So for the other outcomes that I review is that they presented in the STS are experience with the aortic arch surgery and transposition of the great arteries. And you can see we totally review 176 patients, and we're 31 that they need any aortic arch intervention. The most common, it was a hypoplasia of the transverse arch with a coarctation. And you can see that we use a homograft as the main source for reconstruction of the arch. And reality is these patients, they have a lower AP index. There was no difference between the coronary anatomy. You can see here the data on that. And the reality, the patients that they have a hypoplastic aortic arch were more a double outlet right ventricle type in this population. You can see the numbers here in our patients. And these patients require more closure of the VSD through the right ventriculotomy. And there was no difference in between the groups, most likely. You can see that the ECMO run is most likely the same. Now maybe can be biased because the arterial switch is a more population. And the mortality is almost no difference. Now, what we found is down the road, the patients that require aortic arch augmentation require more reintervention on the pulmonary artery. This is our follow-up at 10 years, 15 years, and you can see it at 15 years. The follow-up is 92%, 96% on the group. And some of them, we have a loss of the follow-up because patients did not come back for the follow-up. And here I'm gonna just show that on the PA, we have re-intervention, but it's most likely cardiac cath intervention, balloon stent intervention on the PAs. It's a little bit higher to have some of the residual VSD that require an intervention. But in the long-term follow-up, there's no surgical arch re-intervention in these patients. The same, what I was already mentioned, that these kids, they have more re-intervention in the cardiac cath for the pulmonary arteries. And reality is the arterial switch that has a LVOT that we can do relief. That will be the option. Always consider a Nicairo or Rastelli, and always the patients that don't fit in Rastelli or Nicairo, always consider a single ventricle pathway. And you can do a Glenn, let it grow, and then later you can decide if they need to go to biventricular repair. And for taking home, this is a team approach, as already you guys saw everybody talking, the 3D models, review the image. Management of the LVOT requires always visualize the pulmonary valve, the right ventricle, to have a very successful approach. And there's no one size fits at all surgery. So I always say, if you can visualize the surgery, you should be able to do it. If you cannot visualize the surgery, it's gonna give you problems on the next days. Okay? Thank you for your attention.